Hi, Raju. How are you doing today?
Very well, Michael. Just everything is good.
I'm sure you have
I have
read
to-
a very interesting paper for us, and so I'll let you give us the topic of today.
Yes, Michael. Actually, one of my favorite movies of yesteryear was that classic western, The Good, the Bad, and the Ugly with Clint Eastwood. So as I was browsing the net to see a suitable article to discuss, I was really intrigued by this title, which said Colchicine, the good, the bad, and the ugly, and how to minimize risks.
So, colchicine, a very interesting and important drug. So, I'm sure you got a lot of learnings for our pediatric colleagues. But let's start with a question on colchicine. What is the commonest side effect of colchicine? And so I'll let you a few seconds think about it, and then we will continue. And at the end, we will give you the answer.
You know, Michael, reading this article did not give me too much of learnings for the pediatric standpoint. It's dominantly for an adult audience, but I did pick up some pearls from it.
Okay, so let's dive in.
Before that, Michael, let me just ask you which are the conditions in which you have used colchicine regularly?
So, Raju, you know my interest in autoinflammatory diseases, and really, this is a topic where I use the most colchicine. Indeed, for familial Mediterranean fever, where it should be given all lifelong to patients, other autoinflammatory diseases, and also for PFAPA patients when they have very frequent flares. So I got some experience with this drug and sometimes also for Behçet's disease.
Right. Also, there is mention about its usage in patients with recurrent aphtha. Very uniquely, I have used colchicine in patients with cutaneous leukocytoclastic vasculitis. And also, it is actually, I call it the poor man's biological or the poor man's drug for hyper IgD or mevalonate kinase deficiency. We now have three patients with MVK who very fortunately have responded to colchicine because we do not have IL-1 inhibition available. It's also, I have used it in children with juvenile dermatomyositis and calcinosis, and I've read about it being used in amyloidosis, but we have not seen too much of amyloidosis except one or two patients where it is going on as an add on drug. And I must tell you about another kid. I had this child with recurrent idiopathic pericarditis, and I have used it in that girl.
We have also the same experience with recurrent pericarditis. And this is an important drug because if you give steroids to these patients, they have a much quicker recurrence of their pericarditis.
So, you know, its usage has a very interesting principle, Michael. If you notice the mechanism of action, colchicine dominantly accumulates in neutrophils, and the majority of its effects are mediated through its ability to, kind of bind to tubulin monomers, and thereby it prevents the formation of heterodimers of microtubulin. And these are involved in various cellular functions. It also inhibits the NLRP3 inflammasome and alters the adhesion molecule expression in endothelial cells and neutrophils, and therefore leads to a reduction in neutrophil adhesion and recruitment into inflamed joints.
But this is very interesting because neutrophils are important cells for autoinflammation. And when you speak about NLRP3 inflammasome, again, it's going to autoinflammation. And also, for example, neutrophilic dermatosis could be linked to this drug. And gout in adults, indeed, where it was shown that IL-1 beta is playing an important role.
There was the most stunning thing I found in this article. Adults have started using it, some emerging role in coronary artery disease and in postoperative atrial fibrillation.
This is indeed unique.
True. But Michael, there was another bit of a disturbing issue. Colchicine is a substrate for P glycoprotein, which is present in the gut wall, kidneys, liver, and in the blood brain barrier. And its primary function is to facilitate the excretion out of the body to protect against toxicity.
And this explains the drug interaction with other drug using a similar pathway. Notably, in children, we use calcium channel blockers, different conazoles, macrolides, cyclosporine.
Yes, and when you mentioned calcium channel blocker, we use diltiazem in patients with calcinosis. So I will definitely make sure I stop combining colchicine with diltiazem because this could potentiate colchicine toxicity.
So interactions, drug interactions is really a big caution we need to keep in mind when we use colchicine.
True. But Michael, what are the adverse effects that you have seen in your practice?
So what we see is diarrhea or diarrhea or diarrhea. Really, this is the main side effect what we see in our patient, and this will really limit the increase of dose of colchicine that we can use in our patient, especially for FMF patients, where sometimes we have to increase the dosage up to 2.4 or 2.5 milligram per day, and there often we have the problem of limitation by diarrhea.
Two, I too have not seen more than diarrhea as an adverse effect, but the authors do recommend dosage reduction in patients who have severe liver disease or renal impairment, which they define as creatinine clearance less than 30 ml per minute, or when on the drugs that you just mentioned.
But you see, the main problem what I see also with this drug is because we are pediatricians. And so there are children at home. And if these children can have access to this drug, they could take a few pills and die because of this. And so my caution, what I give always to parents, is to keep the drug out of reach of the children. And this is a very important point. And I also point to the parents that the therapeutic margin is very, very low.
But have you seen any cases of colchicine poisoning?
No, I did not, fortunately.
Well, fortunately, I would say. But if there were a known or suspected overdose in a patient, what would you do or how would you approach it?
So first, very early a gastric lavage and activated charcoal that may help. But the problem is that the drug is staying very short time in the blood and is very quickly going to the cell. So it's very difficult to use like hemodialysis or plasma exchange to take away the drug. So really the use for this is very controversial. So really what we need to do is to do a supportive therapy. If we know that a patient has taken too much of the drug, it needs to go to the hospital to be in observation, and then we have to take care of the patient, intensive care unit if it's necessary because of multiple organ failure. and especially because there is no antidote yet available.
So, Michael, this is quite frightening. You have told me that this drug has a very narrow therapeutic index and there is no real antidote, and the progression of poisoning is very rapid. So, while I was reading this article, I learned a very fascinating fact. Gout is disproportionately frequent in indigenous Maori and Pacific peoples who live in New Zealand. And very uniquely, the poisoning center in New Zealand, who reported 56 cases of poisoning over an approximately 5 year period, 43% with colchicine poisoning were children between 1 and 4 years of age who had reached out to the medicine chest at home and got poisoned accidentally.
This is a very important information that we need to disseminate to our adult colleagues because we take care of these problems often because we know the children, but adult physicians sometimes forget that there could be children at home. So, really, this is a very important point. But now that we went through this article, I propose that we go back to the question we were asking. What is the commonest side effect of colchicine? And as you told it, it's diarrhea, nausea, or skin rash, or acidity of heartburn. This is not something what we really encounter in our patients. But now let's go to another question. And this is about the main treatment for colchicine poisoning. So we just show the question and let a few seconds to the audience to look at it and think about the answer.
So, for those, Michael, who are listening rather than looking, let's give them the four options. It's largely supportive, plasma exchange, hemodialysis, or a specific antidote.
And so, Raju, the answer is A, that we need to give a supportive treatment to these patients because plasma exchange and hemodialysis will not work or not very good because the drug is not staying in the blood very long time and there is no specific antidote. So it was, as usual, very interesting. Thank you very much, Raju.